So I'm going to talk to you a little bit about a lot of things we're doing in the celiac world for new therapies and to make lives for patients better. But I think first, we can't really get into that until we answer the first question is why bother, right? 10 years ago, no one would have been doing this. It was really, the gluten-free diet was fine. This is why we developed therapies for so many other conditions. But celiac disease was sort of left to die because we really thought it was fine, right? It was a dietary therapy, it was safe, people were better. What more was there really to do? And that's changed due to a lot of work. And some of that work has been done right here by David's group. A great study, just looking very simply, were patients happy? And it turns out they really weren't, right? I mean, if we can't even understand whether patients are satisfied with the treatment, we're not doing a great job as clinicians. And this was pretty much opposite of what everyone expected. People expected most people would be good to excellent because they don't have to take pills, there's no medicines, all that stuff. But it was really not. Most people were really not satisfied with the gluten-free diet. And this was really, one of the first signals, I think, to us clearly that there was more work to be done. We followed this work up because we really liked that study and to try to see if it was replicatable in the United States, which it was, but also to compare how people with celiac disease felt about their therapy to patients with other disorders. So other common disorders, so we have high blood pressure, reflux disease, renal disease on hemodialysis, type 1 diabetes. And remarkably, what we saw was that the only disease where people liked their treatment less than celiac disease was hemodialysis. Type 1 diabetes on insulin, inflammatory bowel disease on biologics, all of those people were more satisfied with their therapy than celiacs were on gluten-free diet. I mean, this was sort of astonishing to us. But it actually wound up to be true, and this has been validated in a number of different ways. One of my favorite was anecdotally at a meeting of kids with type 1 diabetes and celiac disease, probably about the same size as what's in this room. And it wasn't me, it was actually somebody else who thought to ask, raise your hand if which therapy, if you could cure one, which disease would you cure, the diabetes or celiac disease? About 2/3 of the kids raised their hand for celiac disease. And it was a little bit, because diabetes has lots of complications, we know this as clinicians, but we don't think about a lot is that you can hide your diabetes from your friends. You take your insulin in the bathroom, it doesn't really show up at school. With gluten-free diet, everyone needs to know. Every time you put something in your mouth, your disease is sort of at the forefront. And this really is a burden that never goes away for people on a gluten-free diet. And it's something that has been really underestimated, I think, by us in the medical community for a long time. So not only do people not like the disorder, they also often don't feel better. And I think we knew this in adults for a while, but more recently have come to recognize, as we just heard, that kids are not immune either. And actually, this is non-responsive celiac disease, people who are on a gluten-free diet to the best of their ability, but still having ongoing signs and symptoms. And what you see in adults and children is actually very similar. 40% have clear gluten exposure leading to symptoms. The rest of these doesn't mean they're not getting gluten exposure. It just means that it's harder to determine. Actually, we think that a lot of the people who are called IBS or functional GI symptoms who have celiac disease really have just low levels of gluten exposure that we haven't had the sensitive tools to test. And I think these are going to change a lot with the technology we just heard about to measure gluten. And I think a lot of this will shift into that green. I'll just point out that the only real difference between children and adults in non-responsive celiac disease is that refractory celiac disease and microscopic colitis seem to be very rare, virtually unheard of in children, and are somewhat more common in adults. But otherwise, this is a problem that extends across the lifespan, and really is yet another call to arms to be doing more for our patients. This isn't just in America, those two studies are, but this was already shown once today, but that the majority of patients are getting exposed to gluten on a regular basis. This is a study out of the UK, out of Hall's group, and even the yellow, the people, that minority who say they aren't, many of those that we just heard still get exposed to gluten, they just don't know it. So gluten exposure is virtually universal. I think we should look at that as inevitable. Everyone with celiac disease is going to get exposed to gluten. It's just a matter of how much and how often. And finally, some more recent data. So we thought, just like we used to think that gluten-free diet was easy, we used to think that intestinal healing was fairly universal. And this was a great study done by Ben Liebal and Jonas Ludvigsson with the Swedish database, showing that across the age span, this is your chance of healing, right? So you go from, or chance of not healing, I guess. You go from, so for the average age of celiac disease diagnosis in the 40s right now, you have about a 50-50 chance of ever healing your intestine completely. But even in kids, you only have about an 80% chance. So 20% of kids who are still growing, who are still developing, are at very high risk for long-term complications of celiac disease or not healing their intestine either. So across the lifespan, we're not doing a great job at even getting patients into mucosal remission, to use sort of the IBD terminology. Something that we're seeing across diseases, across inflammatory diseases, that the goal of therapy should be to control inflammation, to achieve a normalcy of the mucosa. And this is something that we're not doing routinely in celiac disease. I don't believe we have the tools to do it yet. And even for the people who heal, it's years. So a third of people will heal after 2 years and 2/3 after 5 years. So imagine putting somebody on a biologic for IBD and saying, you'll probably heal in 3 or 5 years. We would never accept that for another therapy. And I don't think we should accept it for celiac disease either. And just finally, it's not without morbidity and even mortality. These are a number of studies across Europe looking at the mortality ratio compared to the general population, and almost universally higher. This usually improves, but not back to baseline on a gluten-free diet. So if I haven't convinced you yet in these slides that we need something more for celiac disease, let me just give you one analogy I don't have a slide for, of another disease that can be largely treated by diet, but yet it's pretty symptomatic and occasionally leads to life-threatening complications, including cancer. Sounds a lot like celiac disease. It actually applies very well to acid-related disorders, to reflux, right? So those are disorders that can lead to esophageal cancer. It's pretty uncomfortable for those of you who have ever had reflux. And although you can make the argument that acid blockades is sort of overused, I don't think any of us in the patient community or the clinical community would want to go back to a time when all we had to offer for reflux was diet. And I think we'll be looking at that same paradigm, hopefully in the next couple of years, for celiac disease as well. So moving on, with that, I think we've made the argument through work done really across the world, that there's more to be done in celiac disease. And so we have a number of different therapeutic classes, and I'll be hitting on predominantly the top one and the bottom one. So we have interluminal therapies, things that work mostly in the intestine, don't really get into the body. They deactivate, detoxify, protect you from gluten in different ways. And there's a variety of them. I'll be talking a little bit about all of those. I'll be leaving the immunosuppressants alone. They are stronger, more toxic therapies in general, probably good for refractory celiac disease, but probably won't be good for the more routine other 99% of patients with celiac disease. And then, potentially most excitingly, there are immunotherapies, things that act directly on your immune system to try to reinduce tolerance. We're not born with celiac disease, we get it. So if you turn it on, you should be able to turn it off if we're sort of sophisticated enough with our immunology. And I'll be talking about those at the very end, just a bit. So just quickly, to illustrate the pathophysiology of celiac disease, we understand very well, and this allows us to target therapies. And so what happens? So we normally sample, all of us normally are sampling what's going on in our intestinal lumen, and we have little dendritic cells picking up little pieces of this and that, checking it out, and basically most of the time, if we're healthy, we generate mucosal tolerance, homeostasis. We're sort of just surveying and keeping track of what's going on in the lumen of our intestine. Something happens though. You have a breakdown, a GI bug, a medicine, a stressor, and you get this influx of antigens. And this can be anything. It can be gluten, it can be peanuts, it can be microbial antigens. And this starts some inflammation. You then get this vicious cycle leading to more inflammation, opening up these tight junctions, more antigens, more gluten, more whatever gets in, and then you have this break of tolerance. This is sort of fundamentally how we understand celiac disease, development of celiac disease, and persistence of autoimmunity and intestinal damage in celiac disease. And so you can stop this any place. You can stop it up here, you can stop it down here, you can stop the process in here, theoretically, and really cut off celiac disease and allow healing and disease resolution. So liraglutide acetate is, as far as we know, is a tight junction agonist. So this decreases intestinal permeability. It blocks this step. So tightens these things up so things can't get through like gluten anymore. It's novel, first in class, doesn't get into the blood, it just hangs out on the barriers of intestine and keeps gluten from getting in. So in an initial study, a gluten challenge study, just done by symptoms, you see, as you'd expect, people with celiac disease who get exposed to gluten get symptoms. They also get gluten toxicity, which is a combination of symptoms and signs like dermatitis herpetiformis flares. And people who got no gluten and got drug did very well. Optimistically, people who got gluten and active treatment and drug did almost as well as the people who didn't get any gluten at all. Had a little bit of symptoms, and when you kept that at specific gluten toxicity, it was basically the same. So really seemed to protect against symptoms of gluten exposure. This was very promising. There were no biopsies done, unfortunately, and some of the other things like lactulose mannitol for intestinal permeability didn't really turn out, although that's a very tricky test to do in real life. This was then tested in a much larger trial looking at patients who had ongoing symptoms, so those non-responsive celiac disease patients I talked about before, which are a mishmash of different causes in reality. And over a 12-week trial, you see that the active dose of liraglutide had a significant improvement, made people feel better pretty quickly compared to placebo and the other treatments. So this is promising. This was a phase 2b. It's hopefully going to go into phase 3 in the near future. Although some of the things that I will just point out that are big unknowns and concerns about this, these were never done with biopsies. We don't really know. We know it's making people feel better. We don't really understand how. And as you see here, the lower dose was the active one. The higher doses didn't seem to do much, which is not how we typically like to see drugs working. So it's given us a lot of pause, and I think it's, again, there's a lot to be said. A lot of great work's been done in this program, but I think at this point there's probably as many questions as answers. But it does appear to be safe and does appear to make people feel better, which is always important. So the next therapy that's come along pretty far is this ALV003. So this is a combination of fungal enzymes that were recombinant and produced to break down gluten. And this was a clever little study where they just took 4 people, not with celiac disease, just regular people, and fed them the enzyme and a gram of gluten, and then did a gastric aspirate and took out the food and saw how much of the gluten was broken down. Sort of that 1 gram of gluten, in general, about 95% of the gluten was broken down within a fairly short time in the stomach. So seemed to have, biologic activity in the way that we wanted it to make small gluten exposures safe. This was then repeated in really what I think is the new standard for gluten challenge studies, where they did a pre and post biopsy, so it wasn't just symptoms. This was all done in Markku Maki's group in Finland. They took patients who had finished well-treated celiac disease, and put them on a gluten challenge, 3 grams a day for 6 weeks, and did a pre and post biopsy. And what you see is this is down is worse, down is more damage. Patients on drug basically stayed about the same, roughly, whereas patients on placebo got much worse intestinal damage. This is lymphocytes, so this is villocyte to cryptoph ratio. This is lymphocytes getting worse. Again, up is bad here, down is bad here, showing about the same thing, that it seemed to really protect people from a pretty big gluten load over a sustained period of time. So they went along and did that same type of non-responsive celiac study where you take patients who aren't feeling well and try to make them better. Because that's, I think, how we would predominantly like to use this in clinical practice, right? And I'll walk you through this, but it didn't show, the punchline is it didn't show what we were thinking it was gonna show. So they did the same, they did biopsy pre and post, and they took patients who all of them had long-standing celiac disease, all adults, all with ongoing villus damage at enrollment of the study, so that's different, and randomized them to a variety of different doses of the enzyme, and then did a follow-up biopsy, and they had symptoms measured throughout. So this is villocyte to cryptoph improvement, so improvement in intestine, and so up is more improvement. And what we didn't expect to see is that placebo improved a lot more than drug. So this led to some consternation, and I'm glad I didn't own stock in the company. But I think this tells us a few things that are really important and sort of get missed in the message of, oh, it's another failed celiac study. The first is that these are adults who had long-standing enteropathy, who hadn't healed despite years, an average of, I think, 4 years on a gluten-free diet, and still had a lot of ongoing damage. And yet even they, on placebo, were able to heal significantly in 12 weeks. So that's a really empowering message that that people can heal. Even, that wasn't clear to any of us at the time when this study was proposed. We actually thought we might not see any change in any of the groups, even if patients felt better, just because 12 weeks isn't a very long time. And we know, as I said before, it takes years for patients to heal. But here we see when patients are very tightly controlled, and this was an incredibly burdensome study with daily diaries and multiple visits, they can actually get better pretty quickly. So I think this shows how much we can actually do to improve celiac disease. For symptoms, it got a little bit better. there was something of a symptom improvement, but what you do with that when you have less, I mean, everyone improved, right? Don't get me wrong, everyone improved. This didn't improve as much as placebo. The other finding that came out of this was that people who were seropositive, who had a positive TTG at entry, was about 25% of this study, had a much more, what we would much more expect. They had more improvement with drug, and they had more improvement with symptoms. And so what I really wish we had, which would have tied the study together but just wasn't available, is that gluten immunogenic peptide test in stool and urine. Because if we had the serology and we had actually what people were getting exposed to, then I think we would really understand what happened to this placebo group and how we could really identify the patients who would best benefit from a therapy like enzymes. And this is important because there's new enzymes coming. And this is Coeliac. This is actually really exciting. It's the first medical therapy that I'm aware of that's entering clinical trials that's a purely synthetic enzyme. So it's designed not by nature, using some design principles of nature, but designed by computer. And it's an enzyme that has, depending on who you're talking about, 300 to 500 times more efficacy in breaking down gluten than the alvine enzyme. It's also more stable in acid. So it's really exciting work that came out of the University of Seattle. And we don't have any human data yet, but we do have some in vitro data looking at bread and products. And this is the alvine enzyme that broke down gluten slowly in bread, but did break down, and if you gave it enough time, versus the Coeliac enzyme, getting down to virtually, basically lower limit of detection within minutes. Did it in beer as well, and showed most of the same thing. Alvine enzyme, slow but significant degradation in gluten. Coeliac, once you add it, the gluten's gone. So I think this is a much more powerful enzyme. And the question is, can we take the lessons from that alvine trial and make a better trial and combine it with a better drug and actually have a therapy that makes a lot of sense to patients and will be able to use, in the same way a lactate pill could be used, potentially. So I think this is exciting, and I'll be interested to see how this work progresses in the next year or two. BL7010 takes the other route. Instead of chopping up gluten to make it inactive, it actually binds up gluten to keep it out of the intestine. And this is a nice, again, non-absorbed, it's a nice theory. This is actually, last I heard, was going under for a device marketing, not a drug marketing, so it's a little bit of a different pathway in Europe. So potentially could become available in the near future. We have some pretty limited data, mostly in vitro, but showing that it actually can bind up gluten and keep it away from the immune system, which is in the end all we really need to do to protect against these 100 milligram, couple 100 milligram accidental exposures, which are probably the thing that are getting most of our patients most of the time. Moving on to the immunotherapies, again, I think the long-term goal of celiac disease therapeutics should be to turn off this abnormal immune response. And there's a couple of people looking at this right now. This is NextVax, it's Bob Anderson's work. He did a lot of the pioneering immunology in celiac disease in Australia back throughout the 80s and 90s. And gluten, just to remind us, it's not one peptide. If it was, it would be much easier. It's actually thousands of related peptides, which have made it hard to design an immunotherapy, an allergy shot-like therapy. But Bob's work was able to actually take these thousands of peptides and generate 3 immunodominant peptides, to which you can then inject subcutaneously under the arm. And interestingly, when you give people a little shot of these peptides in the arm, they get their celiac symptoms. They get diarrhea and vomiting, which is interesting because it actually shows you that this is having some actually immune effect on the place where you need it to. It's not clear, though, whether that's a therapeutic effect and whether that's a toxicity that will make the therapy difficult to use in real practice. So they're about to start a phase 2, a much larger study this year. It's a really novel approach and exciting. And the last therapy that I want to take you through quickly is this new tolerogenic immunoparticles. This is a complex slide. I won't take you through it. But it turns out that you can make particles of specific size and specific charge out of the same stuff that absorbable sutures are made out of. So a safe material that we've been using for decades. And you can fill them with whatever you want. And these home specifically, you can adjust the size and charge to make these go wherever you want in the body, interestingly. Specific cells will take them up. And so this work has been done to develop these particles that actually home in on the spleen and the thymus, the centers of immune regulation. And by filling these particles with gluten, the theory goes that you can actually convince the body that gluten is a self-protein, so you shouldn't attack it, and you shouldn't have this ongoing inflammatory cycle, and develop really turn it from an inflammatory T-cell response to a regulatory T-cell response. So again, a really novel, interesting application that if it works for this, could also work for type 1 diabetes, for rheumatoid arthritis, for all these other autoimmune disorders where we sort of know what's being attacked, but we don't have a way to turn it off. We don't have human data, but we have some interesting mouse model data showing that this is the drug, showing that it does, in the mouse model, for what it's worth of celiac disease, this therapy actually works better than a gluten-free diet, which are the circles here. So you have less weight gain. So this is patients, mice patients on gluten-free diet, this is drug, and they also have more improvement in histology. So I think the preclinical data looks promising. It's stuff that's safe. It's just gluten and absorbable suture material, so there's nothing that we expect to go wrong, because as we just heard, we know we have gluten in the serum anyway. That's why we can find it in the urine. So an interesting, potentially big platform technology. So before I end, I just want to talk about one of the reasons I'm so excited about celiac disease therapeutics and have been for so many years. And one of the reasons is I really believe that the development of effective celiac therapeutics will make lives a lot better for people, even if they never take a pill. And that sounds a little bit paradoxical, but there are actually lots of examples of this in medicine. I'm going to give you one that's going to be a little bizarre in the beginning, but bear with me, and I think hopefully it'll make sense. And this is erectile dysfunction, right? That's not something you expected to hear about today. But if you go back and read some of the medical history medical textbooks, through the about 1980s, erectile dysfunction was considered an uncommon psychological disorder. And actually from the main textbook, written in just 1979, all sexual dysfunction is caused by a single factor, anxiety. So what did people do when they went to the doctor? They got sent to the psychologist. And it's easy now to say, well, silly urologists, silly doctors, how could they think that? But that's not really any different than what we do for celiac disease. We just send them back to the dietitian. Any problem you're having, go back to the dietitian. And I think there's actually very little difference between a good celiac dietitian and a psychologist. They actually are doing much of the same work. And then suddenly, we had some therapies in the 1980s, and then all of a sudden you had the sea change. 80% of erectile dysfunction cases stem from physical problems. It was this new realization, wow, it's not all behavioral. There's actually something medical, organic here that we can work with. And this sort of led to the urologist, to the physician, not the psychologist, being the one to sort of design care pathways and understand how best to treat people. And what this led to, not just a lot more clinic visits, was a lot more research. And this is why we know things like good diabetes control is important for erectile dysfunction. Beta blockers are bad for erectile dysfunction. These are things we only learned once we had good therapies to target and sort of say, this is how much better we can make patients. What else besides the therapies can we do to make patients that much better as well? So I actually think that this is something that we are going to see in celiac disease as well. And a lot of the questions that Jeremy was asking, a lot of the technology that we heard about with gluten peptides will be answered in patients, and it'll improve the lives for patients, again, even if they never get a prescription for a celiac disease medication. So that's the goal. Hopefully, my optimistic worldview will turn out to be the case. So just to conclude, we've learned a lot about celiac disease, but yet I think our outcomes and standard of care are suboptimal. We're doing the best we can, but we have a long way to go. I think we now recognize that, and that's actually the first step. Like to anything, the first step is admitting you have a problem. It's the same with celiac disease. And effective treatment and monitoring strategies are really lacking, as we heard about already. And this, again, makes patients less likely to come to the doctor and talk to us about the problems. And I think in the future, really novel therapeutics are going to change the landscape of celiac disease in fundamental ways that we can't even imagine. And so I'll just end with this plug for ICDS, the Celiac Symposium in India. I hope to see a bunch of you there. I think it's going to be a really exciting program. So thank you again for inviting me.
Questions from the floor? Microphone at the back to Hugh, please.
I'm a pediatrician, and I've got concerns about using drugs, immunotherapy, particularly in kids. And I want to give you a devil's advocate view here. You said 10 to 15% of children still have evidence of enteropathy, even though asymptomatic TTG normal, and 50% of adults. I would say to you, so what? what data are there that makes a blind bit of difference longer term? I know your argument about mucosal healing. I would say to you there are no good data. It makes a blind bit of difference, and I would rather put up with that, being devil's advocate, than saying, let's try a new drug on kids.
Yeah. No, I mean, I think that's a very fair point, and I think we are lacking a lot of the important natural history studies that we need. I mean, I think intuitively, chronic inflammation doesn't seem to ever be a good thing. Almost all the data we have comes from the Swedish database, showing that, yes, failure to heal leads to an increased risk of lymphoma, increased risk of fracture and bone density problems. Most of those are from adults, and I have to, they're single, Sweden is not the world. Again, so I think there's really a huge case to be made for better long-term data to understand the risks and balances. I also think it's a very individual. If a patient is totally, in my practice, if a patient is asymptomatic, living and doing well, and has a little bit of enteropathy, I only treat adults, but, I'm not gonna torture them and make them neurotic looking for every little bit of gluten. There's a price to be had, and I think it depends, we're gonna have to be very cognizant of any safety, especially if we're putting kids on a celiac treatment that they could be on for decades. I completely agree with you.
Daniel, thank you for that presentation. I was going to ask regarding lorazepam and ALV, any side effect profiles to these?
Right, so no, so it's not detectable in the serum, and it really has had a placebo-like side effect profile in the 1,000+ patients it's been looked at. Of course, rare things can happen, but I think maybe this is related to both points. I think our bar for a celiac disease therapeutic safety profile should be extraordinarily high. The gluten-free diet has a lot of issues, but it's non-toxic in a certain way. So I don't think we will accept, I wouldn't as a clinician accept a significant safety profile for a celiac disease therapeutic. So I think we have to be very targeted and very careful about that.
Last question from the floor.
Very interesting. Paul Secretariat, London. The new enzyme therapy that you presented, which I think is very interesting, are they considering, one of the things that I find surprising in this approach is that many of the investigators focus completely and totally on gliadin and don't look at glutenins as well. Glutenins have a completely different structure, and only if you're going to block the effects of both of them is this going to work. The question is the enzyme strategies. Are they looking to work, be effective with glutenins as well?
Yeah, so I think that's a great question, and one of the limitations is that we don't have great ELISAs for the glutenin peptide epitopes the way we have for the G12 and the R5 really target the gliadins. And so just from a measurement point of view, it's been easier to document and assess gluten degradation than glutenin degradation. I think from the Alvine, gluten challenge data, at least, that protected the intestinal mucosa, seemed like it was doing both. But I agree. I think we don't actually have, I think there's some interesting data with mass spec, new ways to really evaluate whether we're getting rid of all the important epitopes. But I think, lacking human trials to really make sure that gluten exposure doesn't lead to damage to the intestine is the only way to really prove that we're getting rid of all the toxic gluten epitopes.
Just a slight plug here. I have a set of monoclonal antibodies to the other toxic epitopes.
Oh, we'll be in touch.
Thank you very much, Dan.